My name is Joseph Nadler. I'm a third-year resident in internal medicine, and today I'm going to be presenting about ultrasound POCUS during the code blue situations. So in this presentation, we're going to discuss how to integrate ultrasound during CPR, how to use POCUS to identify the reversible causes, how to use POCUS to identify potentially shockable rhythms, and discuss the use of POCUS for assistance with CPR, and then discuss use of POCUS for the prognosis of the patient who is currently in cardiac arrest. So integration, I thought this was a nice picture. It kind of shows a well-run code. You have everybody nicely spaced out. You have somebody doing chest compressions off to one side. And then as you notice, there's somebody here who's dedicated to use the ultrasound alone to help identify potentially irreversible causes. They're using a probe that might not be thought of as useful for cardiac ultrasound, however, is recommended to use this probe during the code blue situation. So overall, I thought that this was a nice picture to kind of show how ultrasound can be integrated during code blues. So it can be difficult in improperly trained environments to integrate ultrasound because people might not know how to use them properly during these. If you've been in a code blue, you understand that there's hundreds of people who rush in the room, and it might be difficult to get ultrasound into that room. And then ultrasounds at some hospitals are difficult to find, and so lack of accessibility. One of the principles that have always been mentioned is that you can't interfere with CPR to use ultrasound because the CPR is obviously the most important part of a code. But it also must be used early because as the code progresses, one, you're potentially harming the patient by not identifying a reversible cause, but also some of the physiology changes in that patient, and you don't necessarily see, you might confuse some of the signs with each other. And then you also need to select a probe that will work for all the tests needed and has a small footprint. The probe that is most recommended by the literature is actually the curvilinear probe, because you can get lung ultrasound, you can get subcostal view with it, you can get abdominal ultrasound with it as well. The other ones that are recommended are the phased array probe or the cardiac probe, because you can also get most of the images that you need with it, but you can also get it has a smaller footprint. The linear probe itself, which is commonly used for a vascular ultrasound, might not get it won't have the ability to get abdominal ultrasound or cardiac ultrasound in most cases, so it's not recommended to use that ultrasound. And as you know, a lot of the handheld ultrasounds have kind of a dual probe, so using a handheld ultrasound with a dual probe can work if it switches between the probes quickly. So the most important thing to look at with CPR or with cardiac arrest is the heart. You want to look at the heart, and to look at the heart, the best view to do during ultrasound is going to be the IVC and the subcostal views, the subxiphoid views of the heart. Mainly because they're below where CPR is going to be occurring. You can kind of adjust it with CPR. You don't have to interrupt CPR. If you see something that you need to check out, then you can obviously move to the apical four-chamber or peristernal long, as long as they don't necessarily interfere with CPR. And then again, echo should be conducted early, because the right ventricle and the left ventricle will equalize in pressures as time progresses during the CPR. So this is just kind of a view. I just wanted to show what this looks like. As you see, the probe is underneath the chest wall, so or underneath the rib cage. This is on a child, but and so CPR will be occurring up, on the chest, and then the probe is below that. This view is also nice because it gives a good view of the right ventricle. If you get a good view, it'll get a view of all the ventricle or all the chambers of the heart plus the pericardium, and then you can easily shift over to the IVC to check what it's looking at. So it's a good view for this situation. So once you do those views and check the heart out, you can perform other exams if they're indicated. So you can do a pulmonary exam to look for lung sliding or B lines, or just quickly look at the lungs. You can also look for DVT if you suspect that there's a PE, and then abdominal exam, which is not something that I expected to see during this, but if the patient's hypovolemic, then checking for a ruptured free fluid in the abdomen or a ruptured aorta or something that caused this rapid hypovolemia. And then also the carotid ultrasound used during pulse checks and rhythm checks to help determine whether or not they have return of spontaneous circulation. So one of the most unique things that I thought was interesting about ultrasound utilized during Code Blue is actually identifying potentially shockable rhythms. On the top here, you can see kind of the difference. On the top here, this is what is a fine V fib, and on the bottom here, this is asystole with some artifacts. During a code with on a CP, you're not printing out a 12-lead rhythm strips. You're looking at only from a defibrillator. These can often look really similar. And so actually using ultrasound to look at the heart to see if it's in fibrillation or if it's in cardiac, if it's in asystole, then you could potentially identify that's something that I can shock. And as we know, shocks and CPR, shocks and compressions are the two things that save patients' lives in CPR, not necessarily FB, not necessarily these other interventions. These are the two main things that we should be focusing on. So identifying a shockable rhythm is really important. So they can be difficult to interpret, and then POCUS is really useful for off the bat seeing, is there a potentially shockable rhythm? And then another useful factor with this is identifying the reversible causes. Just quickly, the H's and T's are something that you can focus on. It's a good mnemonic to remember how to remember the reversible causes, and you always say, let's run through our H's and T's. And the ones that you can identify with ultrasound pretty easily, hypovolemia, cardiac tamponade, tension pneumothorax, and pulmonary thrombosis or pulmonary embolism. For these other ones, I was hypo and hyperkalemia, hypothermia. You can see some signs on. You can see some signs on echo, like the heart might not be contracting as it should, or there might be some weakness to it and things like that. But in general, hypo and hyperkalemia are going to be diagnosed by labs. Hypothermia is going to be diagnosed by temperature. Thrombosis, not necessarily see that. You won't see that on echo. You can see some signs, wall motion abnormalities, those types of things. Hypoxia, again, diagnosed by labs. So these are the four that I focused on as kind of the ones that you can see by echo. So patients coding, you do an ultrasound, and this is what you see. You see, this is the IBC ultrasound. You see a subcostal view of the liver, and then the IBC running underneath it, and it's completely collapsed, effaced. The diagnosis that you can make right off the bat is hypovolemia. You can also, in this exam, look for the chambers of the heart, look for underfilled chambers, that type of thing. But if you see a collapsed IBC, the recommended next steps would be to check for some sources of the fluid loss. So check the pleural space for a large pleural effusion. Check the intra-abdominal space for a intra-abdominal fluid. Check the aorta for potentially ruptured aorta or aortic aneurysm or something. And then obviously that should, if they're hypovolemic, you should initiate you should fluid bolus them, which could potentially lead to ROSC and save the patient's life. Some other signs that you would see with hypovolemia, you could see some, like I said, fluid in the abdomen, fluid in the pleural space, those types of things. So that's an easy one to identify with ultrasound, and it can be difficult if you don't have a ultrasound to identify hypovolemia in these patients, because they're not going to have jugular venous distension, those types of things. So the next one that you can see easily with an ultrasound is pericardial tamponade. This is not during a code blue ultrasound, this image, but I thought it was a good example. You can see a large pericardial effusion. You can see the right ventricle that's collapsing. The right atrium is effaced. This patient is in tamponade, most likely. And so rapid identification of a tamponade in this situation, you can see it through the subcostal view. And if the effusion is seen, you should check the IVC. And if the IVC is dilated, then tamponade is likely the cause of the cardiac arrest. There are some other signs that you can see of tamponade, but within a cardiac arrest, it might not be as easy to do, and you don't have the calculations that you can. And really, time is of the essence in those situations. And so when you identify a tamponade and you see a dilated IVC, your next steps should be calling somebody in who can do a ultrasound guided pericardiocentesis, or if you're comfortable doing it yourself, because getting that pressure relieved, getting that tamponade relieved will hopefully lead to ROSC in these patients as well. So in this one, you see a underfilled, this is, maybe you don't see an effusion, but you see the left atrium and right atrium and right ventricle are they're underfilled. You see a dilated IVC, and then you don't see, this is not in mode or a video, but there's no lung sliding or anything like that. And so in that case, the diagnosis would be tension pneumothorax, which is, again, pretty straightforward to identify in these situations. So if you see all those signs with the absence of lung sliding, assuming they haven't been intubated yet and they're or they have been intubated and they have equal breath sounds bilaterally, and the tube is in the right place, you can identify that and potentially lead to ROSC by a simple needle decompression, relieve that tension of the pneumothorax. And then in this situation, you see a dilated right ventricle. The septum is bowing. You see the IVC is dilated. And there is a small pericardial effusion in this situation as well, but it's not, you wouldn't see a dilated RV with a tamponade. So with this situation, the dilated RV and the dilated IVC shows you that there's increased right ventricular pressures, and the likely cause in this patient would be a pulmonary embolism. Again, there's other signs that you can see of a pulmonary embolism, such as McConnell sign, D sign, all these other signs, but these can be difficult to obtain during a cardiac arrest, just because of the nature of where you have to place the probe to see, like a McConnell sign. You have to get apical fourth chamber, and these types of things. So pulmonary embolism, if you see a dilated RV and a dilated IVC early in the code blue, that would likely point you towards a pulmonary embolism. So after that, but this is where your scan needs to be conducted early, because as you do chest compressions, as CPR conducts, the right ventricle and left ventricle's pressures equilibrate, and so you can get what looks like right ventricular overload without actually having a DVT or a PE. You can also scan, you can also scan the lower extremities to look for thrombosis after you see this dilated RV. If you see a DVT, then it's a slam dunk that you probably have a pulmonary embolism, and then you can do thrombolytics or send the patient to get a thrombectomy or an extracorporeal CPR as your next steps that you should consider during these situations. So one thing that I also thought was interesting about utilizing ultrasound during a code blue, you can actually help with CPR. So there was a study that I was looking at. It's pretty old, but carotid, they were having providers do a carotid pulse check, and they had actually clamped the aorta. I'm assuming this was a simulation, but they had clamped the aorta of the patient, so the patient did not have a pulse, and they were doing a pulse check, and it was approximately 30% of patients, or 30% of providers would say that they had a pulse when they clearly didn't with this clamped aorta. So we're not the best at checking pulse, especially during high pressure situations, and so ultrasound is actually better. You can see a carotid pulse with an ultrasound a lot easier than you can feel it. And then also POCUS can assist with compression locations. These haven't been completely validated and aren't necessarily in the recommendations as of yet, but using POCUS to identify, are the compressions good? Are you getting point of maximal compression? And then one issue with that is that when you do that, the thoracic aorta typically runs really close to the heart, and so when you compress the heart, you can also compress the aorta, and then that's kind of leads to poor blood flow. And so using ultrasound to say move your compressions a few centimeters to the left or to the right, where you're not going to be hitting that aorta, you can actually see the compressions in real time and say, okay, there's blood flow through that aorta, that you're getting good compressions with that. So I thought that was interesting, although not necessarily recommended in the guidelines at this time. And then prognosis, we've already talked about, fine AFib or fine VFib versus asystole with artifacts, but actually with PEA and asystole, ultrasound can be useful for just prognostication as well. So if there is some cardiac activity in these patients, there have been a few studies to look at how with PEA and asystole, if there's any cardiac activity, whether or not there's actually what likelihood they're going to get ROSC, and they quoted in the paper 33% in if there's PEA asystole with cardiac activity versus only 14% without, 50% versus 40%, and it can be detected in 33% of patients with PEA and asystole. That sounded really high because 50% of patients don't get, like it just almost never happens, but it certainly can help you with prognosis to determine whether or not these patients will have a better chance at ROSC. And then there was a strong likelihood ratio. Another paper was saying that if there's no cardiac activity detected, that there's a strong likelihood ratio that they're not going to have ROSC. And then there was a moderate increase, I think a likelihood ratio of about 4 or 5 if they did have some cardiac activity, which seemed a little bit more likely to me. So POCUS can be useful. In conclusion, POCUS can be useful to help determine if the rhythm's shockable, if there's a reversible cause, potentially help with CPR and help with prognostication. So it's a really useful tool to have in these high stressful situations. And actually the current guidelines recommend integration of POCUS into the ACLS protocols when you suspect a reversible cause. But I believe that's probably going to change soon into just saying you should have an ultrasound available. But the issue being that more providers need training in POCUS during cardiac arrest, and that would be beneficial to kind of help them go through all these guidelines. So these are my references, and that is the end of my presentation.